Ladies and gentlemen, welcome to the Young Physicians Forum and College Lecture. We are going to start the Young Physicians Forum and College Lecture afterwards, and the lunch will be distributed afterwards. And for the Young Physicians Forum, the first lecture is by Dr. Vinoth Sobana, Pharmacovigilance, the crucial role of the physician. She is a senior registrar in clinical pharmacology and therapeutics, National Hospital of Sri Lanka. Over to you, Sobana.
Good morning, everybody. It's my privilege to be here to present in Young Physician Forum today. So, my topic is pharmacovigilance, the crucial role of the physician. So first, I'll see the outline of my presentation, introduction and epidemiology, history of pharmacovigilance, the role of the physician, and how to report and how to recognize adverse drug reactions. So the name pharmacovigilance, pharmaco is mean the drug and vigilance is mean monitoring. So it is drug monitoring. The World Health Organization give the definitions that the science and activities related to the detection, assessment, understanding, and prevention of adverse drug effects or any other possible drug-related problems. The second definition is most easy to understand. It is that when the drug is available in the market, so the pharmacovigilance, when the drug is available in the market, we should monitor the safety and effectiveness throughout. So, is it the pharmacovigilance only the monitoring of adverse drug reaction? The answer was no. It includes other that medication errors, counterfeit medication, lack of efficacy, abuse and misuse of medicines, and interactions of medicines also include in the pharmacovigilance. Then, what are the medicinal products that was under the pharmacovigilance? Not only the medicine, also included biologic, vaccines, blood products, and traditional and complementary products and herbals. So, do you wonder that before approval of a drug, the drug undergo the strict clinical trials and they are testing the safety and efficacy, everything before approval of drug. Then why we need this pharmacovigilance even after it comes to the market? So, because in the clinical trials, usually it is run only a short-term period, and usually only less than 5,000 individuals who are selected people, so they are incorporated in the clinical trials. But when it comes to the market, that used by a lot of people, their genetic and their age group and their other disease comorbidities are varying, and it was a long period of time also. So some adverse drug reaction can emerge even after the approval of drug. And if you think one adverse drug reaction, if example, if you take one adverse drug reactions incident is 1 in 10,000. So it at least needed 30,000 people should use the drug. So if before the marketing, we can't find out some of adverse drug reaction. That's what throughout the when we are using the drugs, we should vigilance about the drug. So, why we want to worried about this vigilance? Why we need this? Because it is a very common thing. Yes, because when we take the non-communicable disease, The morbidity is caused this adverse drug reaction the 4th to 6th place in the worldwide. So 10% of hospital admissions are due to the adverse drug reactions. Even in the Sri Lanka, 2017, there's a study was done. It even shows the 4th leading cause in hospital admission due to the adverse drug reaction. The main adverse drug reaction is the hypoglycemia. Then we see the history of pharmacovigilance. There's an interesting story that because 1957, the medicine named thalidomide was introduced, and it was a very short period, it got popular. Then it was prescribed for the pregnant woman to avoid the morning sickness. But after that, they found the babies born into the pregnant woman are congenital deformed. Their limbs were abnormal. So after that, the world recognized that thalidomide was banned, but then reintroduced only for this cancers, for like multiple myeloma. Still we are using, but not used for the pregnant woman. So it is the main turning point of pharmacovigilance. After that, the WHO created International Drug Monitoring Institute in 1968. Then these are some example of medication that was withdrawn after spontaneous reporting. So when we take the history in the Sri Lanka, in 1999, the Department of Pharmacology and Faculty of Medicine incorporate with the Ministry of Health and start the pharmacovigilance unit. In 2001, the Sri Lanka was admitted as the 59th member of the World Health Organization Drug Monitoring Program. And 2015, the NMRA Act was came and legalization of the pharmacovigilance came. Then we see the main role of physician in the pharmacovigilance. The physicians play a key role in the pharmacovigilance. How? Because the physicians are the people who are directly contact with the patients, and they are prescribing the medicines and monitoring the adverse drug reaction and managing the medicine. So they will encounter a lot of these adverse drug reaction, and the physicians they are reporting the adverse drug reactions also. This lead to identify and analyzing pattern of adverse drug reaction, and it can improve the drug safety and facilitate evidence-based decision making. So then we will see what's the definition of adverse drug reactions. It was when whatever the medicine, when we are giving in a therapeutic dose, we are giving for a benefit of effect, but without our unintention, there's sometimes the bad effect, the noxious effects can happen. So that means the adverse drug reaction. The art of the medicine consists of amusing the patient while nature cures the disease. So then I'll go through some of studies that was relevant to the adverse drug reaction reporting. So study was done in Sri Lanka. It was published in British Journal of Clinical Pharmacology 2018. It found that the physicians play a major key role. They are 71, the total reports, 71% of adverse drug reactions are reported by the physicians. Then in 2020, another study was done and published in the Journal of Clinical Pharmacology and Therapeutics. It evaluates the knowledge and attitudes of physicians towards the pharmacovigilance. It shows the majority of physicians have positive attitude to report toward the recognition of adverse drug reaction, but lack of time and unawareness of reporting system were the common barriers. So the study suggests further education and training to enhance the physician engagement in the pharmacovigilance activities. Then there are several studies was done in even Sri Lanka pharmacovigilance system that found the physicians play a contributory role in identifying unknown adverse drug reaction, because that help to improve the patient outcomes. So now we see what are the things we need to report. So all suspected reactions of new medicine. New medicine in the sense after coming to the market, it up to 5 years it take as a new medicine. So whatever the adverse drug reaction offered, even it's a minor or major, whatever things we should report. And all serious or unexpected suspected reaction for the well-known medicine. So if example, if we take the penicillin, if there some patient got, if he suspect, for example, because of penicillin, Stevens-Johnson syndrome is occur, so we should report to that and increase frequency of a given reaction. If we know, if we take example again as a penicillin, usually everybody know it can cause anaphylaxis. But if a lot of anaphylaxis come due to the penicillin, we should report to the pharmacovigilance service. Then the fourth one, that any interaction with medicine food or medicine with herbal, medicine with medicine, everything we should report. And adverse reactions in the special field of interest, like medicine abuse or misuse, we should inform, report. And then if the harmful effect to the fetus and infant due to the medicine, that should also report. And then when the medicine withdrawal, if any adverse drug reaction occurs. For example, if you see, take the benzodiazepine, when it withdraw, it can maybe cause some suicidal ideas. If we thought, if we suspected that, then we should report that. Then overdose or medication error also should be reported. And lack of efficacy or pharmaceutical defects, that also should be reported. In recent times, Sri Lanka face some medicines like immunoglobulin and coamexicolate and ceftriaxone are some of that pharmaceutical defects was identified because of reporting to the system. And then we saw the important thing, how to recognize the adverse drug reaction. As usual, we go with the history examination and differential diagnosis and laboratory things. And first we take the history, but here we want to take the medication history very detailed, and we want to ask the person, are they took the medicine at what they prescribe at the same the dose, and we want to ask. And we want to ask what's the relationship of the onset of adverse drug reaction and when they took the medicine. For the time period, we should clearly ask. And it is immediately following the administration, or maybe after long time after administration, because some adverse drug reaction can happen immediately, like anaphylaxis, but some like leukopenia and thrombocytopenia can happen even longer than. So then we see the physical examination. The physical examination, some physical examination is for the adverse drug reaction, like fixed drug eruption and steroid dermal atrophy, that everything is specific for the drugs. But some drug, that urticarial rash or some rashes, or if Stevens-Johnson syndrome, that we can find in this physical examination, but not particular for the specific drug. Then laboratory test usually used for find the complications or any other problems occur for the diagnosis and treatment. But we can measure the drug level to see the some drug. We can measure some drug like gentamicin. We can see is it toxic or subtherapeutic or normal level. So we can correlate with our clinical finding. Then we should tell it is possible or it is a probable diagnosis we want to conclude. Then we want to think about the other possible thing also. If hypoglycemia maybe can cause of anti-diabetic medication, but even insulinoma also can cause hypoglycemia. So with the history and other examination and laboratory things, we can come to a differential diagnosis. And then we want to see the effect of D-challenge. D-challenge means if the patient was on medicine, we want to withdraw the medicine and see if the adverse drug reaction is it is disappear or it is resolved. And re-challenge, we want to administer the drug again, but usually it is not it is unethical in usual situation. But there are some situations, if the benefit is more to the patient, we can re-challenge the medicine. In example, after snake antivenom, we can, after even anaphylaxis, we treat the anaphylaxis, then we want to re-challenge, re-administer anti-snake venom. So then finally we want to, if we suspected any adverse drug reaction, we should report to the relevant authority. In Sri Lanka, we should report to the Pharmacovigilance unit, to the National Medicine Regulatory Authority. Like infectious disease, when we are suspicion, we are notified to the relevant authority. Like this, if we suspicious about adverse drug reaction, we would report to the National Medicine Regulatory Authority. It can be reported either online or reporting as a form. We can download from the NMRA website. So we can address to the Chief Executive Officer NMRA, and that either way we can report. So this is the form we can download from the adverse drug reaction. We can fill this and we report to the NMRA. And this is the, they have a separate form for the anaphylaxis reporting. And when to report? That's the main question, because it usually, if the serious side effects like anaphylaxis or life-threatening effects, or if it is Stevens-Johnson syndrome, that should be report within 24 hours. Otherwise, before the, at least before the patient discharge. Because if they have any queries, they can call you and they can find out more clarifications. If we report later, sometimes the data may be inaccurate. So benefits of reporting, as usual, it is enhance the patient safety and quality of care, and we can even get the self-satisfaction. And we see the pharmacovigilance in the special population, because usually the clinical trials are not include the children and the elderly people and the pregnant woman. But now they are incorporated the children and elderly people. But usual things is still the far away to go for, because in the clinical trials, if they didn't incorporate these people get more vulnerable because of drugs, because we are using off-label drug therapy to these people. And the dosage may be not be correct. So some adverse drug reaction not common in these people, and adults maybe get another adverse drug reaction. So when we prescribe a drug to these people, we should more vigilance. And these are the challenges of reporting adverse drug reaction: lack of awareness and voluntary nature of reporting, because we should voluntarily report, and workload and difficulty in establishing causality, and lack of feedback and communication from the pharmacovigilance to the reporter, that also cause disinterest to report. And the established pharmacovigilance system, if that not that much established, also one of the challenge we found. And then how to reduce the adverse drug reactions. So as usual, the education that will lead to more that will lead to reduce the adverse drug. If we educate more and more, and if we have some sessions, and then that everybody is aware to report these adverse drug reactions, and we can use now that artificial intelligence or some already programmed programs, apps also we can use in reduce adverse drug reactions by we can there we can feed the common drugs and what are the side effects usually come, what are the cautions. So if we prescribe in the busy schedule every drug interaction, the doctor can't maybe they can't check. So if we prescribe, let example, if we prescribe some drug like losartan, then if we already feed to the AA system that it will so that we need to monitor the serum creatinine, serum electrolyte. So that are the things that should be automatically come, that apps we can use, or we can see even the drug interactions also we can see. And the other thing, and the warfarin is the main drug, usually have a lot of interaction with food and difficult to control. The INR maybe is over therapeutic or sometimes sub therapeutic, or and when the patient going to a GPs and they are prescribing some drug that cause interaction. So this is, I thought that if we made a list of the common medicine that was interact with the warfarin, and if we paste back to the that patient who take warfarin, the patient can show it to the every doctor that they are treating. At least the doctor can see any possible interaction via that list, so they can at least double thinking before prescribing the drug to the patient. And next thing, when that recently also happened about the that in Sri Lanka that immunoglobulin that drug is not standardable, so it causes even death. So if we can check what are the medicine that was registered in the NMRA, because we can open the NMRA website and go to the registered medicine. There, if we type the brand name, it will show it will registered NMRA or not. So that if cross check before the new brand of medicine, if we are prescribing, it is can also prevent lot of adverse drug reactions. And then finally, this is I came to the take-home message. The physicians usually play a vital role in the pharmacovigilance, and whenever the adverse drug reaction occur, it should be reported to the National Medicine Regulatory Authority. That mainly thing as soon as possible. That usually at least before the patient was discharged. And every suspected adverse drug reaction, if we if we report to the NMRA, that will enhance our patient safety and overall medicine effectiveness. And these are my reference. And finally, I thank to the Ceylon College of Physicians for the wonderful opportunity they gave me to present in the Young Physician Forum, and the Department of Pharmacology, Faculty of Medicine, University of Colombo, all my teachers and mentors for the guidance. Thank you so much.
Thank you, Dr. Sobana, and now is open for questions. Yeah.
Thank you for the wonderful talk. Is it legal to prescribe unregistered? Right?
No, sir. It is not legal. We can't prescribe the unregistered drugs.
It is a donation. It is a donation coming to.
Whatever it is not legal, sir, without unregistered.
unregistered medicines cannot be prescribed as a general rule, but donations we have a separate set of guidelines. As much as possible, the Ministry of Health must ensure that the drug is registered. On the other hand, if the ministry has approved and it goes through the industry to the prescribers would be prescribing in a generic way. So that might be an unregistered place. Donations have a different set of rules. Sobana, can I ask you two questions? Thanks. That was very interesting and very timely topic. One is you said that there was a study where the majority of the reporting had come from physicians. Do you know the numbers that we get to the pharmacovigilance unit per year of the reports that comes to the unit? That is the first question. The second one is you were talking about re-challenging. So would you recommend re-challenging in every instance, or are there certain caveats that we should know when we are re-challenging? Thanks.
Yes, madam. Even though the physicians are reporting that 71% that mean that all reports they came with that 71% by physicians, but actually it was very reduced amount of. Actually, I don't know the actual number, madam, but it is very reduced number of amount that is coming to the pharmacovigilance unit as by report, because we actually every physician usually they identify and treat the adverse drug reaction, but for my knowledge that reporting is not that much established. When we are comparing with the notification of dengue or infectious disease, we are mostly report. We are usually notified, but for the adverse drug reaction, even every adverse drug reaction, even anaphylaxis and everything, we are usually very lack in reporting. And other thing, madam asked about the re-challenge. Usually, re-challenge is unethical, but if the patient have more benefits, if we think the physician more benefits than the risk, we can re-challenge. That is very few incidents only there. As I already told, that anti-Cinec venom, if we got even anaphylaxis, after treating anaphylaxis, we can re-challenge.
Thanks, that's fine. Yeah, just to say that unless you have no other option, then the challenge is justifiable. Otherwise, it's actually putting the patient into more harm. Thank you. That is good. Thanks.
You said 4% of the hospital admissions are.
Yeah, it's the 10% of hospital admission for the non-communicable disease. Yeah, drug. Even because even hypoglycemia is a drug. Yeah, and even hypertension, everything is adverse drug reactions that we can prevent.
Thank you very much, Sobana. And we are running out of time. Yes, a very brief question and very brief answer.
Just I want to know whether the unregistered products are available in the market. So it is actually not a question, but I mean, if those are available.
Yeah, sir. And now, because of the crisis, we can the unregistered are there, sir. But actually, it is.
Yeah, can I answer that? Sorry, in a study that we did even before the crisis in 2015, it was an island-wide study. There were so many unregistered products. When you look at the numbers, there for all, we studied 100 essential medicines, and for all of them, there were more products in the market than the number registered with the NMRA. And there's no decrease in the number, even when it comes to 2022, which we sort of compared and studied. So there are a lot of unregistered products, and that's one of the problems that we identified even recently through a situation analysis and something that we need to address.
And sorry, sir, and I went to training for in pharmacovigilance NMRA. They told that they are not doing the post-surveillance marketing. So that is the place they can identify, but because of lack of people in staff people, they are not going for the post-surveillance. And
just one comment about unregistered medicines. That's a very good question. Unregistered medicines are there because not the brands, I'm not talking the brands, but the generic, there are certain products which are registered by the NMRA, but they are available in the market. So they will flourish as long as we prescribe them for various reasons. Of course, the prescribing is the responsibility of the prescriber. So if you prescribe an unregistered medicine, just be aware that if something goes wrong, it's entirely on you.
Yeah, we understand that there's a big enthusiasm in the audience about this. We can continue the discussion once the lectures are over. But Civil Project Physicians, thanks Dr. Vinoth Sobana for this wonderful lecture.